This hallucination sounds like they're external. They're not, and it looks like they're having a conversation with themselves because they're answering, they're literally talking out loud. They're not talking inside. They hear this individual is copying back, but a lot of my patients with schizophrenia don't believe that they have a mental illness. If what they're seeing and hearing is real to them, how would they, given information to the contrary, they still hear them, things that other people can't hear. Medication does help and makes them maybe quieter, but it doesn't make them go away. Hello, everyone. Welcome back to Dr. Moss's channel. I am Dr. Moss, the second year psychiatry resident. Let's start. Psychosis. That is the loss of connection with reality around you. That can be with hallucinations, seeing, hearing, feeling things that are not physically there. Your eyes are not actually taking in the image, so it's not physically there. Hearing things that are not at the wavelengths are not coming in, so your brain is producing it. Something really interesting about hallucinations is that they believe they're on the outside. When I'm interviewing someone who says they hear or see things that aren't there, I ask them, is it coming from your head? Or do you know the voice? Do you not know the voice? Where in the room it's coming from? Sometimes I have patients say it comes from something that's been implanted that they actually hear, or physically from behind them, so they can tell it's external to their own self. Versus, I'm sure you have your own thoughts and maybe you remember a thought of someone else talking, but this is different. It sounds like they're external. So people can have full-on conversations. It looks like they're having a conversation with themselves because they're answering, they're literally talking out loud. They're not talking inside. And they hear that this individual is copying back, but they're not, there's no response, but they're responding. That is such a common thing, especially in any psych ward. With someone who has psychosis, you just hear them talking or screaming in their room. Shut up! I've heard people in their room just screaming, shut up, because they don't like this. Would you like someone keeping you awake or saying mean, aggressive things to you? It doesn't have to be aggressive. Things can be nice things, but because literally it's driving them, I want to say crazy. One of the patients I talked to described it really well in that it's like they're in a busy room, like at a concert or a room where everyone's talking and she cannot understand what they're saying. She's trying to focus on a friend, but everyone's talking. So she cannot deal with all these thoughts and all these conversations going on. One of the patients I talked to called it a council of individuals. Sometimes she could talk to one individual. And what I want to talk about hallucination is they don't have to be all the time. Sometimes they're periodic. And that really is what helps us determine what type of mental illness. Do they hear these voices or have delusions all the time? Or is it just during certain periods of their life? And then delusions. There are a lot of different types of delusions, but the main thing about delusion is a thought process that you think of something which is not true and you're hyper focused. And even if you're told contrary information, you're very focused on that delusion. And then disorganized thinking. You cannot think in a straight line or cannot articulate your thoughts. People are listening to you and just it cannot connect of what they're saying. That's called disorganized thinking or a disorganized conversation. A lot of people that you see on the street that are talking to themselves or being angry or saying, I'm going to kill you, but they're not actually saying to you they're going to kill you. They might be seeing the person, the hallucination that has been targeting them and saying mean things to them. That's who they're saying, I'm going to kill you. These are individuals struggling with their mental health. In this example of people with schizophrenia yelling that they're going to hurt someone, they're talking to someone that you don't see. They're more likely to become victims themselves because if they say that to the wrong person or someone who is not able to understand. I definitely had that situation in the psych wards. I'm thinking of a specific incident where they did say, I'm going to kill you. And they stomped all angry in this situation because I didn't let them have their phone because they kept calling the police saying they'd been abducted. I just ignored them or said, hey, can you go to your room? Later, they came back and apologized. I wanted to mention the waking up. I've always heard about it, but had never experienced until recently. I talked with someone who she was like, I don't remember, everything's blurry, but I remember coming here 6 months ago and she didn't recognize the date. It was like this blank period of she remembered getting here and then she remembers the conversation we're having today, but there's this huge blank period. She was in such a psychotic state that mine wasn't actually putting that memory in hippocampus and it was not connecting the hippocampus, which is your memory storage, and your frontal lobe. So there was that psychosis specifically during that time. And I think that was a lot of the legal aspect of determining, okay, during this crime, was your brain aware of what it was doing? Did you believe it is a negative, harmful thing? I was talking about waking up. This lady, she said that she feels like she's woken up, had been taking anti-psychotic medications. She was in a dream state and now she can really think. That's when I know the medication is working, that you're able to have that connection and able to interact with the world. That is our goal. That is good treatment. Let's go back. Let's talk about the different types of psychotic disorders. In my psych unit, what types of psychosis and psychotic disorders I consider. So kind of three different levels that we think about based on the time frame. The one that lasts the shortest is a brief psychotic disorder. That can last anywhere from a day to less than a month. It usually can happen after something traumatic, something very sad, or just randomly. Interesting to note that 50% of people who have brief psychotic disorder have just one, never have one again. They just have one episode. Now 50% do end up having another psychotic episode. And that's where we think, okay, this is not just a one-time thing. Maybe this is a longer lifetime illness. So next is schizophreniform, which can last from 1 month to 6 months. And about a third of people do actually recover and don't have it again. So they just have it for 5 to 6 months. That's it. And they can go on with their life. But unfortunately, 2/3, 2 out of 3 people that have schizophreniform do end up progress to schizophrenia. So DSM, schizophrenia, phrenia. Okay. So, two or more of the following each present for a significant portion of time during a 1 month period. Delusions, hallucination, disorganized speech, frequent derailment or incoherence. Eventually, I'll do the mental status exam and explain it. Grossly disorganized, catatonic behavior. We can talk about another time of catatonia. And then negative symptoms. Negative symptoms can be the difficulty making emotional expression, also called flat affect. Avolition, so trouble having motivation to do things, more of almost like a depression. At least 1 month and then over 6 months so we can develop schizophrenia. And then this is the next criteria. For a significant portion of the time since the onset of the disturbance, level of functioning in one or more major areas, such as work, interpersonal relationships, self-care, are markedly below the level achieved prior to the onset. Or when the onset is in child or adolescence, there's failure to achieve expected level of interpersonal, academic, or occupational functioning. Continuous signs of disturbance for at least 6 months. This 6 month period must include at least 1 month of symptoms that meet criteria A, or less if treated. It may include periods of prodromal or residual symptoms. During these prodromal or residual symptoms, the signs of the disturbance may be manifested by only negative symptoms, so sadness, depression, apathy, or by 2 or more symptoms in A, including odd beliefs, unusual perceptual experiences. And the odd beliefs, we're talking about individuals who have schizophrenia. A lot of people that maybe you see on the street that are talking to themselves or being angry or saying, I'm gonna kill you, but they're not actually saying to you they're gonna kill you. They might be seeing the person, the hallucination that has been targeting them and saying mean things to them. That's who they're saying. I'm gonna kill you. Individuals are struggling with their mental health. In this example that I just provided of people with schizophrenia yelling that they're going to hurt someone, they're talking to someone that you don't see. They're more likely to become victims themselves if they say that to the wrong person who is not able to understand. I definitely had that situation in the psych ward specifically where people that had schizophrenia were very angry. I'm thinking of a specific incident where they did say, I'm going to kill you. And then they stomped all angry in this situation because I didn't let them have their phone because they kept calling the police saying they'd be abducted. I just ignored them or said, hey, can you go to your room? And then later they came back and apologized. A lot of my patients with schizophrenia don't believe that they have a mental illness. If what they're seeing and hearing is real to them, how would they, given information to the contrary, they still just like, no. And this is beyond just the mental health stigma. It's actually a part of the mental illness that it's difficult for them to make two and two of everyone else doesn't see things. So it's only me. I've had individuals with schizophrenia that end up eventually being able to say, yeah, I have schizophrenia, I have hallucinations, I have things that other people can't hear. They still hear them. Medication does help and makes them maybe quieter, but it doesn't make them go away. And that is a conversation I have to have a lot of times with my patients. This will not fully remove them. You might always have these, but maybe they become less triggering. Maybe it can help you be able to get a job, be able to live not just in the hospital, that they can live in a group home or live with their family and family doesn't have to worry about them getting hurt. I really like to compare individuals with schizophrenia like individuals with Alzheimer's and dementia. If you see individuals from that lens, I'm wondering if you have more compassion because individuals with Alzheimer's, I'm still getting on a rabbit hole, but I hope this connects with you, might get lost. They're like, oh, I'm going to go on a walk. And then they cannot remember where they live. They cannot remember who they live with, the names. Individuals with schizophrenia, and notice I don't say schizophrenics, individuals with schizophrenia. We actually looked at the brains and they look pretty similar. Individuals with Alzheimer's, individuals with schizophrenia have reduced brain volume, especially as they get older, specifically their frontal and temporal cortex, which is a lot of the social, the talking, the complex reasoning. Same thing with Alzheimer's and dementia. If you have any more questions with schizophrenia, put them in the comments. I'm really happy to be doing this video to talk about schizophrenia and hope to show some compassion to individuals. It's like it's just like any other mental illness. Think of depression. Thankfully, depression, someone's able to say, I am depressed. When individuals with schizophrenia cannot always say that. It's part of the mental illness that they struggle to say that and struggle to have that acceptance. The same thing with Alzheimer's. Individuals with Alzheimer's have difficulty understanding that they themselves are having memory issues. That's actually part of when we evaluate individuals. When someone says, hey, I'm having problems with memory, we're not looking at Alzheimer's. We're more looking at either normal aging or dementia. Versus if the family is noticing memory problems, getting lost, forgetting things, forgetting the names of people, and the patient is not, then we're more looking at Alzheimer's. Same thing with schizophrenia. It's very common for individuals in their late teens that will develop schizophrenia, more commonly struggle with school, with friends. Maybe they start using substances. I'm not saying that if you drop out of school, start using substances, you're going to develop schizophrenia. But people who later develop schizophrenia have these patterns of struggling and having some sort of mental health, social connection struggle before they start to develop the full-on psychosis. I have to go into this of cannabis because we now know so much more about individuals who have a predisposition to develop schizophrenia. If they have cannabis at an age younger than 24 years old, they have increased risk of going to develop schizophrenia because they already have that genetic predisposition to develop schizophrenia. And then the marijuana kind of wakes it up. And I've seen so many teenagers and young adults where that's happened. No, Just because you have marijuana or weed or whatever we want to call it does not mean you're going to develop schizophrenia. However, if you have a family member that has schizophrenia, if you have that prodromal state, and then you also have cannabis, increased risk that you'll develop schizophrenia. So this is not a medical podcast. I'm saying this is all for educational purposes. Look into it, and I'll include the studies because there's so much out there that we've seen now, and so many kids that I've now taken care of are having a psychosis, and even when they stop having cannabis, that psychotic state continues and develops schizophrenia, even when they stop having cannabis. And it makes it even harder when they keep having cannabis and that psychotic state gets worse. And it's something that we definitely see. Individuals with schizophrenia definitely are more likely to use substances. The thought process is kind of the self-soothing hypothesis of it helps them relax and they're self-medicating, which of course then also makes some of the hallucinations worse. Let's get to the next section. So those are the types of psychosis. Now let's get into something called schizoaffective disorder. It includes the schizophrenia psychotic feature. So all the time there's schizophrenia, or at least having that baseline. And then there are periods where they're either very depressed or have manic episodes. These manic episodes are when they're not sleeping, they're talking really fast, they're having excess energy and motivation to do things that they're passionate about, or maybe slightly passionate about before, but now really want to do it, or do situations that normally they wouldn't. Maybe they become hypersexual, maybe they go gambling. I had a patient who during her manic episode would write and self-publish tons of books on Amazon, and that was just like, wow, you not just have schizophrenia, you have that bipolar feature on top. So that's schizoaffective disorder. And it doesn't have to be that, it can be schizoaffective with very strong depression, having a depressed mood. If you're a medical provider, remember SIGI CAPS, sleep disturbance, interest disturbance, guilt, concentration, appetite, decreased or increased eating. P is psychomotor retardation. I don't like that word, like slowing down, going super slow, and then suicidality. Let's go next to bipolar with psychotic features. This is something a lot of my medical students struggle with, the difference between schizoaffective and bipolar with psychotic features. As I mentioned, schizoaffective is schizophrenia all the time with episodes of either mania or depression. In comparison, bipolar with psychotic features is that you just have that manic episode, and only during that manic episode or only during that depressive episode, you also have psychotic features of hallucinations, delusions. Once you're treated or once you stop having that episode, you go back to normal. These individuals are able to hold a job down. Not while they're in those episodes, it gets difficult. Maybe they have to take medical leave or get a new job because it's so difficult during that episode, but it's a shorter episode. When they're not in those episodes, they can go back to work, they can go back to taking care of their family, have a family. I hope that makes sense, that difference. I've worked with medical students, future doctors that have bipolar. You can see my podcast, Life as a Patient Doctor, where you can have a mental illness and be a doctor. During their manic phases, they just pull out of studying. Maybe they take a leave of absence from school to take care of mental health, or be in the psych ward to protect themselves from doing things that are maybe harmful to them themselves. So again, doctors can also have bipolar. Okay, did you learn any new ones? If you like learning about the medical and psychiatric side of things, make sure you like and subscribe. Let me know what you think. Put them in the comments. I have videos where I talk about more of the psychiatric evaluation and in medical education. So watch one of those videos.